ask me, how am I doing my slides without a laptop and all? So I need to tell you that these days phones have got all facilities and you can have all your presentations on your mobile phone. You just need an adapter to give an output from your mobile phone. In the last 3 years, for every conference, I am only using my mobile phone as my PowerPoint or slide thing. I use an Apple and I use Keynote, but you can also use an Android. And maybe during the workshop time, I'll give a short talk on how to actually use these. Our talk now is the Diwaker Prakash Classification for Supracondylar fractures of humerus.
Sir, any question for the hip?
We do one thing, we are running short of time. So we'll just finish this off and just before workshop we'll do a question for all this and then start the workshop. So I'll cut down one talk after this and we'll just have 3 speakers for foot stack frame where everybody has come here for the Kepard stack frame and Mukherjee method, and so that we can go to the workshop before lunch. We were about half an hour late and we are now running another hour late. So let's carry on a little faster. Now, Dr. Dewakar will be speaking after me about his experiences in supracondylar fracture, and in many thousands of cases he has treated. He has not put K-wires in 99%. He never puts K-wires, and he has not used anesthesia in 99%. All hematoma blocks. And every case has been done in his clinic only. And it is not described in any book anywhere. So listen to it very carefully. Before you understand that, let me tell you treatment algorithms. This is a common place where supracondylar fractures happen. Gartner classification, most common 95% extension types, 5% flexion type. And Gartner classification is very simple. One is undisplaced, 2 minimally displaced in the sagittal plane, 3 displacement in both planes, but some contact is there, and 4 complete disruption. AO classification is based on this only. Now, the disadvantage of both AO and Gartner are, they do not take into account the mechanism of injury. They do not suggest position of elbow immobilization, do not suggest method of reduction, do not suggest the forearm position for immobilization. Children, if you are not putting them in a pin, correct cast in a correct position of elbow or forearm is essential to ensure that the fracture does not redisplace. This is a treatment algorithm based classification. 9 grades of fracture, grade 0 to grade 8, and covers all fractures in full detail. Grade 0 is a green stick fracture, and only sign the fat pad sign. Look carefully at the fat pad, and you see an elevated fat pad, it's grade 0. It has to be looked very carefully, otherwise you miss. Grade 1 are fractures with minimal displacement. Grade 2 are stable fractures with single plane displacement. So this is most commonly associated with the posterior angulation, anterior beak, and this is the commonest supracondylar pattern which we see in our practice. Grade 3 is hinged unstable with medial shift, anterior beak or varus of the limb. You can see in the lower picture. Grade 4 is similar but with a posterior beak and a valgus. Grade 5 is total separation of both fragments. Grade 6 is proximal fragment is piercing into the brachialis. It presents as a blue blotch medially or laterally. And grade 7, oblique supracondylar fractures. These are not manageable conservatively. They are always left with need invariably flexion, external fixation. And this is the last one, with a very rare anterior displacement, the Gardner flexion type, which happens in less than 5% of supracondylar fractures. So what are the algorithms? Grade 1, gravity correction plus ultralight flexion slab for 5 to 7 days. That's all the extent of the slab you have to put. That's all. Grade 3, you disengage the fracture by posterior and side to side movement first before gravity reduction, and it's immobilized in full pronation with elbow in flexion. It may be a bit confusing, but I'll send you a PDF. So next time you do a reduction, you can just read the PDF quickly and then go. Great force, disengage by posterior and side-to-side movement, then gravity reduction and immobilizing full supination, elbow flexion. Grade 5, the periosteal hinge is fully torn and there is a total separation with a wide gap. We reduce by applying gravity in mid-bone, immobilization in full above elbow slam, in maximum flexion possible, in mid-forearm position, mid-prone forearm position. In grade 6 with the proximal fragment piercing the brachialis, we have to milk to free the bone under GA and then apply gravity. Immobilization in prone forearm because they are varus displacements. Obliques, they need closed reduction with pinning or open reduction plating because they do not stay in plaster. And the rarest of the rare, grade 8, they are treated by posterior thrust of the forearm over the elbow condyle flexion and the edge of the table and slab a 90 degrees flexion. This is a very important concept, Dewakar's law of gravity. The weight of a child proximal to the elbow, massed into gravity, exert exact forces required to disimpact and reduce a supracondylar fracture. A supracondylar fracture recoils back, correcting all rotations and displacements by the force exactly equal to the weight of a child hung by his elbow in flexion. Nature has a built-in safety mechanism that gives accurate traction to reduce without any damage to the antecubital skin, vessels and nerves at the elbow. So this is Latin, which he always says that gravity conquers everything. When Dr. Dewakar first described this procedure on social media about 3 years ago, posting a small 1-minute video clip, he had 40 comments all criticizing him and telling him that he was barbaric, he was inhuman and he was going back to the bone setter's days and this is not how supracondylar is managed. He was so scared that he withdrew the post. He came to visit me to Chennai. At that time, my jeep mechanic's daughter fell and had come to my house with a supracondylar fracture. There is a board outside my house, no consultations here. But then because he was a jeep mechanic, he brought her in. And the moment Dr. Diwaker said X-ray, he saw the X-ray. Within 30 seconds, before he could realize he had already reduced it, and then he went to buy the plaster. I took a video of that also, which I posted. Then gradually people started recognizing it. Today over 30 to 50 surgeons all over India are using Dewakar's method to get precise, perfect reduction of every supracondylar fracture. And what is this Dewakar method? This is what Dr. Arvind Diwaker Jain will now present. Come, Arvind.
Thank you, Dr. Prakash. He is one of the surgeons who knows both the worlds, the nether world and the upper world. I can ask him what happens if it is operated. He has answer to everything. And I have answer if not operated, what will become. For every problem, I have a non-operative answer. Just he described that oblique supracondylar fractures, they are very difficult to do. Still, I tell you, every day orthopedics is a learning day. You keep on getting new varieties. And now I have learned how to conquer oblique supracondylar also with non-operative method. Now it has been changed now in between these times. And another thing I have seen in supracondylar, that we have about 1% of cases having collisus fracture as well in children. So don't forget to palpate wrist also, because the child is coming with very, very swollen elbow and we forget to see collisus type fracture also there. So this can be a 10th type. Many of persons coming from abroad, especially Dr. Amjad, please stand up. Dr. Amjad, he understood every principle of gardening very well, and that's why he came from Baghdad just to see and meet us.
And by the way, we have got delegates from 6 or 7 countries who are attending this conference. So we got from Africa, we got from Bangladesh, we got from Iraq,
And I'm very honored and proud that no institution, no organization, no sponsors, everybody has paid money and come to learn. How much more blessed can I be? Thank you very much.
How did I start this gravity method and how did I calculate what is the Dewakar's constant? It was in times 1982. Because I live in a small city and my house is very near to the center of the city and just near to my clinic also. So every patient in the night who had this fracture in child, he came to my house bang, or just please see. And because child is crying, I just cannot say go away, come tomorrow. So I started doing reductions and I had only myself, only one person who has to do X-ray, reduction, assistant, everything. And I started hanging the child for traction and counter traction because I had no one to help me. So slowly I have seen that complications are vanishing. Previously it was taught to us that in flexion you cannot judge the deformity of valgus and varus. So you have to make the limb straight, give traction, and during traction nearly 50% children who has swelling, the skin of the anticutaneous skin broke. They developed vascular complications, anterior nerve palsy, and many other things. And dreadful complication I have seen, that is amputation. I have given 3 amputations in different children, not my cases. So slowly I have learned that why I have stopped palpating radial artery in supracondylar fractures. Then I realized that this complication is vanishing. Now I don't anymore palpate radial artery whether it is patent or not. I know it is patent. So then when I met Dr. Prakash, then we made a system and we regularized thing to teach to the public of India. And now almost every month a orthopedician is calling that please sir come on online video and just inform us how to do this supracondylar gravity reduction. After they pin or don't pin, it is their choice. So now let's start. So I think it's not coming completely. I have written.
No, play by display mode. Play.
Make anatomical reduction a habit. So I have coined few new terms. One of them is ergonomics also, treatment. And I made another comment that I have a habit of habitual anatomical reduction. Anatomical reduction is a habit now. I always get nearly anatomical reduction in 99 or even more. So first thing, it demands knowledge bindings here. If you are doing close reduction, you should know soft tissue where are. You can see the problem here. Radial nerve on the other side and median nerve and brachial artery on the other side. And invariably, the anterior leaking of the proximal fragment, it lifts the artery, damages the intima, make it temporary or a permanent blockage. Permanent is rare. I have got operated only in one case till now, in out of 20,000. So intact soft tissue hinges, bridges, distal fragment after SC fracture is on opposite side. If you see, the intact tissue hinge, if it is an extension fracture, it will be on posterior side. Where the fracture is placed, opposite side is having intact tissue hinge. Like in flexion type, it is on anterior side. So this fracture will be stable in extension because anterior side is tissues are intact. So you extend it, it will be tightened. Same thing happens in extension type, medial displacement, it is on medial side and is stable in prone. And in extension type fracture, laterally displaced, to which side displacement is there is intact, other side is broken. So in extension type, it is on lateral side, this is stable in supine. If you try to reduce in extension, if you are giving it traction in extension, you are pulling vascular neural structure as well as muscles and it is creating damage. And neuropraxia is almost always there if you give traction in extension. Historically, a majority of these fractures are treated with close reduction. This was from my old Campbell. that all the fractures should be treated by plaster only, in traction and extension and plaster. So majority of these fractures were treated with the close reduction along with the arm casting with the elbow in position of greater than 100 degree of flexion. And the problem I had seen in initial days that stiffness was very severe, and even after 2, 3, 4, 5 months, people are coming that stiffness is there. And later I realized if you do anatomical reduction, stiffness is never a problem. Anything short of anatomical reduction will give you stiffness. So slowly I have changed from pinning to no pinning. And after a close reduction, percutaneous pinning maintains fracture reduction without the need of immobilization and with significant flexion. So supracondylar fracture, the commonest injury, 20% of all pediatric fractures and 4% of all fractures, adult and child combined. So dealing with the commonest and most challenging fracture, I think you must have seen plenty of cases of supracondylar, and people are landing into deformities, infection, almost 4% after operation. So dealing with the commonest fracture, most challenging, you must know the best and simplest and quickest way to sort out the trouble. In early 90s, surgical intervention advocated as a standard practice. Use of CR just introduced at that time. Otherwise, we used to take patient in X-ray and doing X-ray repeatedly. Now CR replaced and made the things easy. Allow early motion. Extreme flexions was thought to cause stiffness. Sure, it helped beginner to do all cases easily because the pinning and CR was started, so no one required experience. Anatomical reduction without soft tissue stress is a most sought solution in grateful injury. Difficult to reduce by closed method, as many rotations, displacement, interpositions pose hurdles. Even ORIF, I have seen one of my colleagues just recently operated, it took 1 hour to reduce in open reduction also. Because you don't know what structure to save and from where to get the bone back. Neuropraxia is common and brachial artery risk, stiffness, displacement, not uncommon and need repeat X-ray on day 4 and day 10. It is written in Campbell that you have to repeat X-ray on day 4 and day 10 because redisplacement is there even after pinning. This was old Campbell. It tells that you should do open reduction only rarely. Gartland, Dr. Prakash has just told, if everything is separated in grade 4 and something attached is 1, 2, 3. The fact is varus valgus deformity is hidden in flexion. Hence we are taught to reduce supracondylar fracture in extension only. It has been told that you should make visibly proper reduction and extension so that you see there is no varus. Varus is the main problem. And then after trial reduction, take X-ray to check pulse and plaster and flexion to stabilize by triceps tightness. This was the classic Watson-Jones method. You give traction and straight away, then flex and give it plaster. It is later in 2008 I have realized that full plaster is never necessary. Full plaster is never necessary in supracondylar fracture. I had started giving half plaster from mid forearm to mid arm and it was ridiculed. People have been saying that what is nonsense you are giving. But this is given in Campbell itself that there is no need of any plaster in supracondylar. You can maintain flexion only by elastoplast strip or simply on the skin a plaster strip and put the arm in vest. Banyan ke andar dal lijiye. This is sufficient. You give plaster big or small, you have to maintain flexion only, it is sufficient. Just for the sake of money, I have to give some strip of plaster. Otherwise, it is not needed at all. So this was the classical method, and the fear was Faulkner ischemia, varus deformity, and worst nightmare is amputation, which I have done in 3 cases. Because people have given plaster, even complete plaster, initially in supracondylar, and given analgesic, patient tell them come after 15 days. And after 15 days, patient comes, plaster opened, I could see only bone and dead muscles. Bone opened, I have seen. I opened the plaster, nothing left there except bone. You see, this was operated one of my colleagues. Twice he has operated 6 years back, but the rest of deformity still persists. Hence, pin fixation without perfect reduction is futile. That means that even you should have a perfect anatomical reduction before doing anything you wish. Why CR done OPD not reduced well? You see, this doctor has tried to reduce, but reduction has not come perfect. The reason, less flexion, it can never hold the reduction. Even if you reduce anatomically, if you don't pin, you have to flex it. While we do pinning, poor reduction may not be well visible in C arm also, and we take it as acceptable. This is, it looks like that reduction has been done, but there is a shift in arrow, you see, little shift still passes. And here pinned, and later on they take X-ray and they ask me whether it will be perfect or not. But even this grade 3 is very easy for gravity method. Gravity method takes seconds. And initially, the video I made, people asked that where did you do reduction? Because no one could see, even after slowing. I was not able to explain the people that how do I do it, I just did it. Then I realized how to tell you. You see, this is a reduction, easy. And usually on 10th day, I open the plaster, maintain some flexion, and let the patient go. And he is free on 21st day. Just go home, nothing to be done. And this was a recent case. There was, you could see a vertical split was there. The doctors who has given traction, he separated the piece. And now he went to the surgeon. He said, no, the surgery is very difficult. You will have a stiff elbow. So now he came to me. Again I applied gravity's reasonable reduction. And this is a very particular plaster has been given just to maintain the reduction. And the child is still, the plaster is on, and he'll open the plaster, I'll show you. It is almost normal. Recent case, the reduction is perfect. And after flexion plaster, I give only this much of plaster now. Now, if anatomical reduction is there, the pronation and supination is forgotten now. This will maintain this recently I have discovered that keeping flexion alone, it maintains the reduction, and I check it on 10th day. If it is okay, I give the same plaster again or let him go. Though gravity method invented in 1982 by me, as night calls and midnight, no stand available, had to do all alone, and discovery of featherweight plasters later on transformed the total outcome. Previously my plasters were heavy. And I went to Bombay. I have seen few doctors applying newspaper over the wet plaster. So I thought this is a good idea. It stops the shading and makes the thing stronger. So I started changing the things, and my final things came, which I'll tell you later when I tell you about featherweight plaster in the afternoon. Even the radial pulse checking after reduction is a forgotten caveat, because artery now always safe. And this is the thing, I realized that I stopped checking arteries. So what happened? Then I thought, oh, artery is no more damaged because anatomical reduction is there. A child presents with grade 3 or grade 4 SC fractures. What I do, now I started doing something else also. Humeral nerve lies in the neural ligament, just lateral to the artery. You inject 1 ml, 0.3% xylocaine just by the side of the artery, and the pain of all neck femur, dislocation, fracture femur, it goes. So, in spite of giving analgesic, instead of giving analgesic, I started giving now femoral block in all cases. And then when the anesthetist became expensive, I learned this hematoma block by going to Chennai, visiting Dr. Prakash. He taught me how to do it. And since then, I have never called anesthetist. So, any child who comes to me, I explain if there is a fracture, you will need some analgesia or anesthesia. So, better pay me first. I will give an analgesic block and then go for the X-ray. So, I give only 1 to 2 ml is sufficient, or 0.3%. Why 0.3%? 2% has given cardiac anomaly and deaths in many patients. So, I have calculated lowest concentration which can give hematoma blood, that is 0.3%. Just diluted 5 times. So, any child is coming to me, he gets a hematoma block and he is laughing immediately. There is no pain. Now he can go for the X-ray immediately. He comes back and reduction at plaster in next 5 minutes in OPD itself, because plaster is very small, so it is done very quickly. And I take to minority, only if there is open fracture I have to do cleaning, or if severe brachial artery is there, then I will have to send it to OT. Edema, blisters, whatever the patient is coming 2-3 days, 4-5 days, 10 days, no problem. You reduce inflection, reduction is always done, achieve maximum flexion, and plaster or pin, if there is too much of edema, then I send for pinning. Edema blisters, no problem. Up to 10 days, reduction is possible. And after 10 days, it needs GA and osteoclasis. I have done reduction even after a month in GA, break it, do gravity, again plaster, and the result is same. Although stiffness takes longer. Child is ready to go home within next 10 minutes. If I say that patient is ready to pay, I want to X-ray again. I do hematoma block, plaster and let him go. Just pay me first and then go within 10 minutes. No medicine, usually I don't give medicine. I'll say at the most paracetamol, no antibiotic, nothing else. Unless patient is asking, oh, doctor sahab, koi dawai di, takat ki dawai de do, powder de do, dibba de do. I don't give any medicine. Pinning I reserve only for the rare oblique fracture, as they are unstable or in very anxious parents who ask, doctor sahab, theek ho jayega, nahi ho jayega. A child's weight, Dr. Prakash has already explained, child's weight is exactly what supracondylar fracture needs. Although I don't have much experience of adult supracondylar fractures, I have done hardly 50. So I don't know whether adult's weight is exactly equal. I think adult weight is a little more than what needed. Because the nature has given us built-in safe mechanism to manage this commonest child malady, waiting to be discovered by orthopedicians, more than 5,000 fractures dealt so far with the gravity method in grade 3 or grade 4 supracondylar. Child mass proximal to the elbow into gravity is SC factor. It is accurately what you need to recoil back. The moment you hang the child, all the displacement, varus, valgus, anterior posterior movement, everything will fall to normal and just flex it. Fracture stem current, this I saying. You know the supracondylar fracture in humerus. Flexion type is not less than 5%. I have seen 4 or 5 cases in whole life of 40 years. So I think it is less than 0.1%. Now you can see the proximal fragment, the anterior beak, it lifts the artery and reduces the vascularity. So it has been discussed many times. If capillary circulation is present in nail bed, you should not go for exploration. It comes back. Fat pad sign, Dr. Prakash has not explained. Have you seen this fat pad sign? How many of you? For fat pad sign, you need to do exact lateral X-ray. We have to teach our radiologists how to do it. I think I have posted many times. You have seen either child sitting or doing external rotation in line and lift the elbow by 1 inch by putting a handkerchief. So slight elevation to the table, that will give an exact lateral view, not the flat way. So that way you can see fat pad sign. What fat pad is? Fat pad is a little lighter with the any effusion in elbow. May it be septic arthritis or may it be a fracture hematoma. It will lift the fat pad like this. And you can see, not so clear, but lightly. So if fat pad sign is present and nothing is seen, I have seen it as a radius nerve fracture. And something is seen, that is already there. Supracondylar fracture indication for open reduction is inadequate reduction with the closed methods. Now it is not possible. This is a book entry actually. Vascular injury and open fractures. In open fracture also, now we do not do any more open reduction or take to OT. It is done. Current CR protocol, supracondylar complications, because in extension whenever we reduce, you have neurologic injury 7 to 10%, neuropraxias, medial anterior interosseous nerve most common, and vascular injury. And direct injury of brachial artery secondary to the swelling. Complication after pinning. So I won't go in detail. You have infection or post-operative complication in 4-5% cases. This is very important. Why did I stop anesthesia in children? And I am very old surgeon, and we had only ether when we came to the practice, and it took half an hour to make child anesthesia. Then I started new thing, intrarectal paraldehyde. This is a very good method. You give 10 or 15 ml of paraldehyde intrarectally. It gives as good as anesthesia and totally safe. This I discovered that time only. And then ketamine came, and then everything was solved. And anesthetist was charging only 100 rupees. So it was very easy for me that time. And then I realized Dr. Prakash had informed me that anesthesia is unsafe. And I found out in anesthesia may halt children's brain, and before 3 years linked to and later to mental problems. And from Webmet archives, a new study raising fresh concerns about use of GA in young children. और जितनी बार भी आप करेंगे, any more times you do, brain damage is sure. So it is better avoid general anesthesia unnecessarily. Even I had operation once in 2009, and my nephew, he was anesthetist. He told me, uncle, don't go for GA. Because what happens in old age, any time you will die, nothing, no one will know when it will come. So if you want to get operated yourself, go for the local only. Hence we use only hematoma block. It is totally safe. Previously I was afraid that hematoma block may give you osteomyelitis and infection. And it happened many times that my patient treated develops osteomyelitis. But that was the time when disposable syringe was not invented. We had to boil the syringe every time. And that time, and you know boiling kills bacteria? No. It was Sister Agnes Hunt, 1912, the sister of Robert Jones. She reported a case of septic meningitis having same bacteria of one infected orthoplastidal. The same bacteria was there. So that time, Sister Agnes Hunt, she told that 20-minute boiling is insufficient to kill bacteria. That time, it's only first time known that 20-minute boiling is insufficient. And later on, then autoclave bud developed. So, hematoma blood, we were afraid that it may give infection. I asked Dr. Prakash also whether some osteomyelitis will not occur. He said, no, I have not seen. Then with disposable syringe, simple cleaning, I have never seen any infection. I don't give antibiotic also, but there is no infection at all. So it is totally safe. Use a safe consultation only. Hence we use only hematoma block, and safe and sure way to get instant and lasting instant. The moment you inject in correct plane, you aspirate, and it is difficult. In supracondylar fracture, when swelling is there, you don't know where to find the needle. I have found a way. You go from the lateral epicondyle, slide it up and go inside the hematoma. That is the only way. And in colysis, the safest way to get into the joint is just lateral side of the fracture. There is easy, but the muscles are very thick and you have 24 number needle may not reach to the bone. It looks like that 24 needle is quite long, it reaches to the bone, it doesn't. So use only 0.3% and avoid bupivacaine. I have read about it. Bupivacaine is unsafe, it is having more cardiac side effects. So better avoid in children at least. Other difficulties in total reduction method, assistance required. Old fractures, edema reduces. Have you seen that when you have edema, you cannot give traction. It is a hematoma itself. It resists the traction. Blisters, loss of perfusion, loss of reduction, splitting of splinters, and all these are absent of reduction done in flexion. In full flexion, triceps locks the fracture and need to pin is obviated. So if you wish, pinning is avoided. But if you are not sure, you can pin it. There is no harm. In full flexion doesn't pose any stiffness in 10 days. 10 दिन तक आप रखिए. There is no much problem. 10 days flexion is sufficient. Later on you mobilize and mobility comes within a month. Even no plaster is as good. Just keep the limb in vest with the sling. But prudent to apply slap for placebo's sake. Hence we keep it light as well. So even a single bandage of 12 gram is sufficient. In 3 to 4 weeks, 50% are already there with our light plasters. Then my method, flex elbow by 90 degree in fresh fracture. Hold the forearm, hang the child by own weight. Check the reduction if required. How do I check reduction? Just palpate both the epicondyle and supracondylar ridge, they are in line. Number 2, see whether the tip of the olecranon is in center, AP and lateral both. It should be in the center of the arm. And third thing, you can check the pulse. And most important thing, if full flexion is achievable, you have reduced this perfect. If you can reduce full flexion, the reduction is done. And flex the maximum and coaxing is a special thing I have to develop. Because there is some gap always left after reduction. So you with both the thumbs, you press it forward you press the fracture fragment forward and it coaxes. Then it even fracture line may not be visible later on. And then lessen the flexion and apply featherweight slab or pin. The video was running previously.
We just run through. छोड़ दो, video छोड़ दो. Arvind ji, we're getting very late actually. But आप just show
So,
this.
child's own weight is exactly what he needs.
Video folder में से निकालिए.
Yeah, then give it. Explanation. It's கொஞ்சம் we are on tighter schedule. You got frightfully late.
We will play the video in the break.
Huh?
Yes.
We can play the video. Play. They want to understand. Say, play. Aram play. Give me a separate folder. Take it off.
So this is the crux, sir.
Huh?
This is the crux.
Is it crux? Yes. Okay. Yes.
Yes,
That one first one.
yes, this one. The made on a model only. She is not having any fracture. So just lift it like this. Hold the forearm here. This is disinfection done by this. You can do it in mid-prone and just lift the child with the whole weight.
So completely off the bed.
Yeah, completely off. It should be completely off the
That's
bed.
the key.
And then you check the reduction, that has been reduced, and fully flex. And then coax. That's all. It is done.
So this type of reductions both for the extension as well as
Yeah, extension and both are reduced. So that's why we say the thing has been changed now. Now classification of extensive flexion not required. But only thing that you cannot fix extension and flexion plaster in flexion. You have to do either mid-prone or slight extension.
Go to 44. No, go to side 44.
Second one. This I have shown in last conference. One of the doctors lying down. Because people have to learn how to do it. This is disinfection done in old fracture. If it is not fresh, you have to disinfect the fracture first. And best disinfection is done on the edge of table and just press down like this. This disinfects the fracture always without any giving traction. Radius head, level you hold it, just do it like this. Reduction is done. Check the reduction, flex, and the thing is done. Yes. You have to check later on whether it is in center for the arm or not. You see, any grade of reduction, it comes immediately. Few examples. Now I won't go in detail. You see this very heavy plaster by some other person could not achieve reduction. Gravity applied on day 10, reduction is achieved in the plaster. See, this is oblique supracondylar fracture. It is also maintained by flexion plaster. You can see the oblique fracture. Even open any gustulograde, very easily reducible gravity. Just you have to give an incision only on the skin so that make the wound slightly wider so that it goes in. Brachialis automatically fall in place, although it needs some manipulation. And you give again flexion plaster, never suture the wound, and the thing is alright. You can see the wound is healed on day 11 or 10. See ROM on day 21 immediately after plaster. This is the ROM just after the plaster. Even adults, the same story repeats. Give traction and give plaster.
So remove the crux at 3 weeks.
I remove plaster on day 10 if patient has already paid me. If not, I give another plaster on day 10. Mobilization I start on day 10. Slight mobilization before second plaster or total mobilization after 3 days.
So traction क्या pronation में देना है neutral position में देना है?
Any position, it doesn't make any difference now. Only if we see that it is not very stable, then we choose flexion extension or something like that. Flexion extension, pronation, supination, it is reserved only for 1% of cases where we feel that stability is not there because of fractures, multiple combination, anything else is there. If it is two-piece fracture, pronation, supination is not required.
Reduction check by check X-ray.
Reduction, there is no need to check actually. We do check X-ray to show the patient and attendant. You see how good we have done. I don't need myself. I tell you, I don't need even any X-ray right in the beginning or later on. If patient is willing to pay me, I'll just do it in within a second and let him go.
How much?
Payment depends upon the anxiety of the patient. The parents are very rich and very anxious. I'll charge same as operation. And if it's very poor, last supracondylar I have done for 140 rupees here.
Do you give the receipt or not?
Eh?
With GST.
No. Last reduction I have done 140 rupees.
उल्टा जा रहा है इसे उल्टा जा रहा है
कीपिंग लिंक में टाइट फिटिंग, दिस इज द की पॉइंट. ऐसी बनियान जो वेस्ट है इसमें ऐसे हाथ डाल के रखना है लाइक दिस. इफ यू डोंट डू दिस द प्लास्टर विल डिस्प्लेस यू बिकॉज द चाइल्ड इज गोइंग टू हैंग दैट एंड दे आर वेरी प्लेफुल, सो they do all sort of things and your plaster or slab will fall off. So this is very important that you put for 10 days the vest is given charge. I tell them don't take out your arm out of the basis. And pros and cons: quick reduction without resistance, anatomical reduction 95%, no humerus injury, no substitute injury, economical. And the harm is expertise required. You need at least 10 or 25 cases to get up to this level. Fracture time and field reduction. If you know how to field reduction, it is easy. Many of the beginners, they just wanted to know. If you want to see the thing again, in the meantime, anyone can come and volunteer. I'll show you again. Okay, thank you.
Thank you very much, Dr. Dewakar. So I think since morning we have definitely had a lot of things not in the books, and even if you take one lesson home and you are able to use it successfully on one patient, I think that this conference is a hit. Now, the next is the most important session of today, where everybody was anxiously asking, and yesterday I got so many private messages that they want to have this workshop first and they want to see this film first. Calcaneal fracture is something everybody sees in our practice. Before AO came in, calcaneal fractures were treated as bag of bones or with a